Hello everyone, and so we will be doing the illustrated textbook of Pediatrics, chapter 15, Infection Immunity, and we will be continuing with the infections, human herpes viruses. There are currently 8 known HHVs that cause infection in humans, HSV1 and 2, varicella zoster virus, cytomegalovirus, EBV, HSV6, 7, and 8. HV8 is associated with Kaposi sarcoma and HIV infected individuals. Other herpes viruses discussed later. The hallmark of most herpes viruses is that after primary infection, latency is established and there is long-term persistence of the virus within the host, usually in a dormant state. After certain stimuli, reactivation of infection may occur. Herpes simplex virus, HSV, usually enters the body through the mucous membrane or skin, and the site of primary infection may be associated with intense local mucosal damage. HSV1 is usually associated with lip skin lesions, and HSV most commonly with genital lesions, but both viruses can cause both types of disease. The wide variety of clinical manifestations are described in the following sections. Treatment is with acyclovir, a viral DNA polymerase inhibitor, which may be used to treat several symptoms: skin, ophthalmic, cerebral, and systemic infections. Asymptomatic herpes simplex is very common and mostly asymptomatic. Gingivostomatitis is the most common form of primary HSV illness in children. It usually occurs from 10 months to 3 years of age. There are vesicular lesions of lips, gums, and anterior surfaces around the tongue, and um, hard palate, which often progress to extensive painful ulceration with bleeding. There is a high fever, and the child is very miserable. The illness may persist for up to 2 weeks. Eating and drinking are painful, which may lead to dehydration. Management is symptomatic, but severe disease may necessitate IV fluids and acyclovir. Skin manifestations, mucocutaneous junctions, and damaged skin are particularly prone to infections. Ulcers have recurrent HSV lesions on the gingival, lip margin, eczema, herpeticum. In this serious condition, widespread vesicular lesions develop on eczemated skin. This may be complicated by secondary bacterial infection, which may result in septicemia. Treatment is with IV acyclovir. So these are the pictures: vesicle ulcerations in gingivostomatitis, and the next picture is eczema, herpeticum, and herpetic whitlows. These are painful edematous white pustules on the site of broken skin, typically of fingers. Spread is by auto-inoculation from gingivostomatitis, and infected adult kissing their children's fingers. A less common cause is contact with genital herpetic lesions. Now, the eye disease, HSV, may cause nephritis or conjunctivitis and may extend to involve the cornea, producing dendritic ulcerations. It can lead to corneal scarring and ultimately loss of vision. Any child with lesions near or involving the eye requires urgent ophthalmic assessment involving examination of cornea by slit lamp examination. Disseminated infection, neonatal HSV infection. Infection may be focal, affecting the skin or eyes, or encephalitis, or may be disseminated. Its morbidity and mortality are high. Infection in the immunocompromised source. Infection may be severe, cutaneous. Lesions may spread to involve adjacent sites, esophagitis and proctitis. Pneumonia and disseminated infections involving multiple organs are serious complications. Summaries: basically, most are asymptomatic. Gingivitis may necessitate IV fluids and cyclovir. Skin manifestation, mucocutaneous junction, lips and damaged skin, and eczema. Herpeticum may result in secondary infection, septicemia, herpetic whitlows, painful pustules on the fingers, and eye disease, blepharitis, conjunctivitis, and corneal ulceration. CNS, aseptic meningitis, encephalitis, pneumonia, disseminated infections is in an immunocompromised patient. Now, the next one is for chickenpox, primarily VC infection, varicella zoster virus infection. Clinical features, these are shown in the figure. They are a number of rare but serious complications that occur in previously healthy children, secondary bacterial infections. And it's staphylococci, streptococci, or other organisms may lead to further complications such as chocolate shock syndrome or necrotizing fasciitis. Secondary bacterial infection should be considered where there is onset of a new fever, a persistent high fever of the first few days. Encephalitis, this may be generalized, usually occurring early during the illness and contrast where encephalitis caused by HSV, the prognosis is most characteristic is a VZV associated cerebralitis. This usually occurs about a week after the onset. The child is ataxic with cerebellar lesions. It usually resolves within a month. Purpura fulminans. This is a consequence of vasculitis in the skin and subcutaneous tissue. It is best known in relation to meningococcal disease and can lead to loss of large areas of skin by necrosis. It may really occur after VZV infection due to production of antiviral antibodies which cross-react and inactivate the inhibitory coagulation factors protein C or S. This results in an increased risk of clotting, which most often manifests as purpuric skin rash. In the immunocompromised host, primary varicella infection may result in severe progressive disseminated disease, which has a mortality of up to 20%. Vesicular eruptions persist and may become hemorrhagic. The disease in the neonatal period. Discuss treatment prevention. Oral cyclovir has highly variable absorption and therefore limited benefits, and is not recommended that immunocompromised children should be treated with IVC cyclovir initially. Oral valacyclovir can be substituted at a later point if organ dissemination has not occurred. Human zoster immunoglobulin is recommended as prevention of high-risk immunocompromised which have deficient T cell function following contact with chickenpox. Protection from infection with human zoster immunoglobulin is not absolute and depends on how soon after contact with chickenpox it is given. And the next one is shingles. Shingles is uncommon and should be just caused by reaction of the latent VZV causing a vesicular eruption in the dermatomal distribution of sensory nerves. That is most commonly in the thoracic region, although any dermatome can be affected. And children, unlike adults, really suffer neuralgic pain. Shingles in childhood is more common in those who had primary varicella infection in the first year of life. Recurrent or multi-dermatomal shingles is strongly associated with underlying immunocompromise, for example, HIV. An immunocompromised individual reactivated infection can also disseminate to cause severe disease. Bullet point is recurrent or multi-dermal shingles suggest a primary or secondary T cell immune effect. Now, the clinical features, complications, exposure, spread by respiratory droplets, highly infectious during viral shedding, and goes to illness. And the viral shedding is throughout the illness. Days incubation 10 to 23, median is 14 days, and viral shedding is expected, and temperature is between 37 to 40 degrees Celsius, and rash comes in crops for 3 to 5 days. Papules develop first, and then vesicles and pustules, and then busts formation. And typical vesicular rash, 50 to 500 lesions start on hand, trunk, progress to peripheries, and but maybe just a few lesions appear as drops of papules, vesicles, viscerale erythema, and pustules at different times for up to 1 week. Lesions may occur on the palate, itchy and scratching, may result in permanent depigmented scar formation or secondary infection. New lesion appearing beyond 10 days suggest defective cellular immunity. Complications, bacterial superinfection, staph, strep may lead to toxostreptosome or necrotoxic fasciitis. Central nervous system, cerebralitis, generalized encephalitis, aseptic meningitis, immunocompromised hemorrhagic lesion, pneumonitis, progressively disseminated infection, disseminated intravascular coagulation. Now, bullet points will watch for a child which can box with fever initially settles but then recurs a few days later. This is likely to be due to secondary bacterial infection. Beware of admitting chickenpox contact to clinical area with immunocompromised children in whom it can disseminate and cause potentially fatal disease. Now, the summary chickenpox clinical features fever and itchy, vesicular rash, which crops up with 7 days complications, secondary infection, encephalitis, disseminated disease in the immunocompromised. Human varicella zoster immunoglobulin, if immunocompromised and in contact with chickenpox or if there is maternal chickenpox shortly before or after delivery. Treatment is very supportive, IV cyclovir for severe chickenpox and for immunocompromised children. And the next one is EBV, infection or infectious mononucleosis, glandular fever. EBV is a causative agent of infection including, but it also involves the pathogenesis of lymphoma, lymphoproliferative disease, in immunocompromised host, and nasopharyngeal carcinoma. The virus has a particular tropism for B lymphocytes and epithelial cells of the oropharynx. Transmission usually occurs by oral contact. The majority of infections are subclinical. Older children and occasionally young children may develop a syndrome with fever, malaise, tonsillitis, pharyngitis, often swear limiting fluid and food intake. Rarely, breathing may be compromised. Lymphadenopathy, prominent cervical lymph nodes, often with diffuse lymphadenopathy elsewhere. Other possible features include particularly on the soft vellus, splenomegaly 50%, metabolism 10%, mycolobular rash, 5% jaundice. Diagnosis supported by atypical lymphocytes, numerous large T cells seen on blood. So, a positive Mrcpch test detects the presence of heterophile antibodies, antibodies that react to antigens for phylogenetically unrelated species such as horse red blood cells. Reactive heterophile antibodies in a patient with compatible clinical features are diagnosed for EBV. The test may be negative in young children or in early children. Seroconversion with the production of antibodies against viral capsid, VCA, IgM, and nuclear antigen, EBNA, unnecessary if Mrcpch is positive. Symptoms may persist for 1 month to 3 months, but ultimately resolve. Fatigue is often a prominent feature in adults and in adults. It is symptomatic when the airway is severely compromised, corticosteroid may be considered in 5% affected individuals. Group A, streptococcus is grown from the tonsils. This may be treated with penicillin. Ampicillin or amoxicillin can cause florid mucobacterial rash in children infected with EBV and should therefore be avoided. Now, CMV is usually transmitted via saliva, genital secretions, or breast milk, and vary via blood products and organ transplants, as well as transplacentally. The virus causes mild or subclinical infections in normal pediatric and adult hosts. In high-income countries, about half of the adult population show serological evidence of past infection. In low-income countries, most children have been infected by 2 years of age, often via breast milk. In the immunocompromised host and developing fetus, CMV is an important pathogen that may cause considerable morbidity. CMV will cause mononucleosis like syndrome, pharyngitis, and lymphadenopathy are not usually prominent as in EBV. Patients may have atypical lymphocytes in the blood formed but are heterophile, antibody negative. Maternal CMV infection may result in congenital CMV infection, which may be present at birth or manifest at an older age. In the immunocompromised group, CMV can cause retinitis, pneumonitis, bone failure, bone marrow failure, encephalitis, hepatitis, esophagitis, and enterocolitis. It is a very important pathogen for bone marrow and organ transplant. Patient transplant recipients are closely monitored for evidence of CMV. Deactivation by sensitive tests such as blood PCR interventions used to reduce the risk of transmission of CMV, including the use of CMV negative blood for transfusion, antivirus prophylaxis, genciclovir for transfusion, and antiviral prophylaxis. Also, if possible, transplant of CMV positive organs into CMV negative is avoided. CMV disease may be treated with IV genciclovir, oral valganciclovir, foscarnet, or cidofovir, but each of these drugs can cause serious side effects. Now, the HHV6 and 7. HHV6 and 7 are closely related and have similar presentation, although HHV6 is more prevalent. Most children are infected with HV or 6 by the age of 2 years, usually from the older secretion family member. They classically cause roseola infantum, also known as xanthomas subitum, characterized by high fever with malaise lasting a few days, followed by generalized with rash, which appears as the fever wanes. Many children, this is the Mrcpch Fop caused by HAV6 or 7, which usually appears as the fever wanes initially on the trunk and then spreads to the face and extremities. And many children have a febrile illness without rash, and many have subclinical infection. Erythema subitum is frequently clinically misdiagnosed as measles or rubella, which are rare in the UK and if suspected, should be confirmed by PCR serology. Another frequent occurrences in primary HAV6 infections that infants seen by a doctor during the febrile stage of prescribed antibiotics. When the rash appears, it is erroneously attributed to allergic reaction with freely. They may cause aseptic meningitis, encephalitis, hepatitis, or mononucleosis syndrome. Now, the parvovirus B19, HPV B19 causes erythema infections, infectiosum or fifth disease, so named because it was the fifth disease to be described of a group of illnesses with similar rashes, also referred to as slapstick syndrome. Infections can occur at any time of the year, although outbreaks are most common during the spring. Transmissions via respiratory secretions for affected patients by vertical transmissions from mother to fetus and then transmission of infected blood products. HPV-19 infects the erythroblastosis, red cell precursors in the bone marrow. HPV-19 causes a range of clinical syndromes and asymptomatic infections common about 5% to 10% preschool children, 65 adults have antibiotics. Erythema infectiosum, the most common illness with a viremic phase of fever, malaise, headache, and neuralgia, followed by consistent rash on the face. Flat cheek, a week later, progressing to maculopapular lace like rash on the trunk and limbs. And complications are rare in children, although myalgia arthritis are relatively common. Adults, aplastic crisis, the most serious consequence of HPV-19 infection occurs in children with chronic hemolytic anemias, where there is an increased rate of red cell turnover, for example, sickle cell disease or thalassemia, and immunocompromised children with malignancy who are unable to produce an antibody responsible for infection agent. Fetal disease, transmission of HPV infection may lead to fetal fibrosis and death due to severe anemia, although the majority of infected fetuses will recover. Summary is usually asymptomatic erythema infectiosum can cause aplastic crisis in children. Crisis can cause aplastic crisis in patients with hemolytic anemia, sickle cell disease, and thalassemia, or the fetus hydroxytalis enterovirus. Now, the enterovirus has human enteroviruses, of which they are including the Coxsackie virus, ecovirus, and poliovirus, are a common cause of childhood infection. Transmission is primarily by the fecal-oral and respiratory droplet routes. Following replication in the pharynx and the gas, the virus spreads to infect other organs. Infections occur most commonly in the summer and autumn. Over 90% infections are asymptomatic or cause non-specific febrile illness, sometimes with a rash, usually over the trunk, that is blanching or consists of fine petechiae. Some children have a history of loose stools or vomiting or a constant history. The child is not usually systemically unwell, but if the rash is non-blanching, admission for observation of parenteral antibiotics such as ceftriaxone negative until negative blood cultures have ruled out sepsis is indicated. Other characteristic clinical syndrome exist and are listed in the following sections. Respiratory virus. Now, hand, foot, and mouth disease, painful vesicular lesions of the hands, feet, mouth, and tongue, and Also, on the adult systemic features are generally mild. The disease subsides within a few days. Herpengia, vesicular ulcerated lesions on the soft palate and uvula causing anorexia, pain, and swelling, and fever. Severe cases may require IV fluids and appropriate analgesia. Meningitis, encephalitis in high countries, enterovirus is the most common cause of viral meningitis. Long-term neurological sequelae are rare. The majority make a full recovery. Pseudodynia, born on disease, and acute illness, severe pleuritic chest pain, and muscle tenderness. There may be a pleural rub, but examination is otherwise normal. Recovery occurs within a few days. Myocarditis and pericarditis, both manifestation is rare. Affected children may present with chest pain or heart failure associated with a febrile illness and evidence of myocarditis on ECG. Eczema, cocciceum. This is enterovirus infection affecting young children with eczema, characterized by cycle, bullet, and erosion. It is easily confused with eczema herpeticum. It resolves spontaneously and tears not. Enteroviral neonatal sepsis syndrome. This rare syndrome occurs in the first week of life, predominantly results in transplacental intraviral infection of the infant. It is thought that transplacental infections result in very high load. Transplacental infections result in very high viral loads, and the symptoms are consequently often very severe, mimicking bacterial sepsis. Affected infants may present with hypotension, monkey organ failure, requiring intensive care support. Currently, there are no antiviral drugs that are effective against enteroviruses. The use of IV immunoglobulins remain controversial. Enterovirus D68, infection enterovirus D3 and D68 can cause mild to severe symptoms. Most are mild infections, including fever, runny nose, and cough. Really, it causes severe respiratory illness or acute febrile myelitis in children. Now, the summary, mostly asymptomatic or self-limiting illnesses with rash, which may be petechial, could cause hand-foot mouth disease, herpangina, and meningitis, encephalitis, and myocarditis, pericarditis, and neonatal sepsis syndrome. Now, the seasonal viral infection pediatric was during the winter full of infant children with seasonal viral infection associated complications. Common infections include RSV, coronavirus, and human metapneumovirus and rhinovirus influenza A. Influenza is an acute respiratory illness caused predominantly by influenza A or B. It occurs in annual winter outbreaks, although in many children, influenza is an acute, self-limited, uncomplicated disease. In some, it is associated with adverse outcomes, and those with underlying immune deficiency, asthma, and neurodevelopment or metabolic disorder are at higher risk. Although most tests for influenza in children occur in previously healthy individuals, spread is via droplets, and children are important vectors for disease within the community. It is highly contagious. Incubation period is 1 to 4 days. Children can have severe complications of virus, myocarditis, pericarditis, encephalopathy, or associated bacterial or fungal superinfection. Pneumonia is a major complication. Treatment for hospitalized children is with neuraminidase inhibitors, which are oseltamivir and zanamivir, which inhibits viral entry and are most effective given early in the illness. Severely ill children may need intensive care with the aggressive management of associated complications. Immunization is the most effective way of preventing infection. Primary school children should receive an annual influenza vaccine. Summary influenza, seasonal viral infections are a widespread cause of illnesses and need hospitalization in children. Influenza can have serious complications in healthy children as well as those with underlying susceptibility. Vaccination is the most effective strategy to prevent influenza vaccine. COVID-19 is caused by a novel coronavirus, SARS-CoV-2. Infection rates are much lower in children than adults, and death in childhood rare. Presentation is children is with cough and fever, runny nose, and sore throat. Some present with vomiting or diarrhea. Many are asymptomatic, they usually develop a multi-system influenza response. Now, the uncommon viral infections, measles, doctors need to be able to recognize measles despite effective vaccine outbreaks continue to occur due to insufficient immunization coverage to provide herd immunity. Worldwide, measles continues to be a major cause of morbidity and death where immunization is not provided. As with chickenpox and HIV-19, older children and adults tend to have more severe diseases than the very young. For epidemiological tracking of infection, PCR-based on histological confirmation of clinical cases of measles should be undertaken by testing saliva. These are shown in the picture. These are a number of serious complications occurring previously healthy children. Encephalitis occurs in 1 in 5,000 cases a few days after the onset of the illness. Initial symptoms are headache, lethargy, irritability, proceeding to seizures, anxiety, trauma. Mortality is 15%. Serious long-term sequelae include seizures, deafness, hemiplegia, and severe learning difficulties affecting up to 40% survivors. SSPE is a rare but devastating illness manifesting on average 7 years after measles infection in about 1 in 1 lakh cases. Most children who develop SSPE had primary measles infection before 2 years of age. SSPE is caused by a variant of measles virus which persists in the CNS. The disorder presents with loss of neurological function which progresses over several years to dementia and death. Diagnosis is essentially clinical, supported by finding high levels of measles antibody in both blood and CSF and by characteristics electroencephalogram abnormalities. Since the introduction of immunization against measles, it has become extremely rare. In low-income countries where malnutrition, vitamin A deficiency leads to impaired cell-mediated immunity, measles often follow protracted course with severe complications. Impaired cellular immune response, such as an AMV, may result in a modified absence of rash with an increased risk of dissemination, including giant cell pneumonia and encephalitis. Treatment for measles is supportive. Children who are admitted to hospital should be isolated. In immunocompromised patients, the antiviral drug ribavirin may be used. Vitamin A, which may modulate the immune response, should be given in low income countries. Clinical features and complications. Exposure rapid spread in day 10 to 14, highly infectious during viral shedding. Viral shedding starts illness and temperatures are given and rash, public spots, conjunctivitis, and coryza in cough. So public spots, white spot on buccal mucosa, seen against bright red background, pathognomic but difficult to see. Rash spreads downward from behind the ears to the whole of the body. Behind the ears to the whole of the discrete microbubble rash initially becomes blotchy and confirmed may disseminate in second week. Complications for AT pneumonia, second bacterial infection, otitis media, tracheitis, nodular fibrosis, EEG abnormalities, encephalitis, subacute sclerosis, and encephalitis, other diarrhea, hepatitis, appendicitis, corneal ulceration, myocarditis. And prevention by immunization is the most successful strategy for reducing morbidity and mortality of measles. Measles remains a major cause of death in childhood in some low-income countries. Measles incidence has declined dramatically since immunization was introduced, but outbreak still occurs when immunization uptake is insufficient for herd immunity. Clinical features: fever, cough, runny nose, conjunctivitis, marked malaise, public spots, macular rash. Complication common if malnourished or immunocompromised is a major cause of death in low-income countries. Next is mumps. Mumps occur worldwide, but its incidence declined dramatically because of mumps component of the MMR vaccine. Following decrease in uptake of MMR immunization in the late 1990s, there has been a rise in mumps affecting unimmunized children and young people. Mumps usually occurs in the winter and spring months. It is spread by droplet infection to the respiratory tract, where the virus replicates within epithelial cells. The virus gains access to the parietal glands before further dissemination to other tissues. The incubation period is 15 days to 24 days. 24 days. Onset of the illness is fever, malaise, and parotitis, but in up to 30% cases, infection is subclinical. Only one side of the face may be swollen initially, but bilateral parotid monomer may occur over the next few days. Parotitis is uncomfortable and child may complain of headache, pain, and eating or drinking. Examination of the carotid duct may show redness and swelling. Occasionally, carotid swelling may be absent. Fever usually disappears within 3-4 days. And plasma amylase levels are often elevated due to parental inflammation, and when associated with abdominal pain, there may be evidence of lymphatic or normal activities for up to 7 days. After the onset of carotid swelling, the illness is generally mild and self-limiting, although hearing loss can really follow months. It is usually unilateral and transient. Now, viral meningitis and encephalitis lymphocytes are seen in CSF in about 50% meningeal signs are only seen in 10% encephalitis in about 1 in 5,000 cases. The common clinical features are headache, photophobia, vomiting, neck sickness, or orchitis is the most real complication, although it is uncommon in prepubertal males. When it does occur, it's usually unilateral. Although there is some evidence of reduction in sperm count, fertility is very unusual. Rarely, euphoritis, mastitis, arthritis may occur. Rubella, German measles, rubella is generally a mild disease in childhood. Typically occurs in the winter and spring. It is an important infection as it can cause severe damage to the fetus. Though this is now rare, the incubation period is 15 to 20 days. It is spread by the respiratory route, frequently from unknown contact. The prodrome is usually mild with low-grade fever or none at all. Microbial rash is often the first sign of infection, appearing initially on the face and then spreading centrifugally to cover the whole body. Fades in 3 to 5 days. Lymphadenopathy, particularly the suboccipital and post-auricular nodes of prominent. Complications are rare in childhood, but include arthritis, encephalitis, thrombocytopenia, myocarditis, clinical differentiation from other viral infections, including enteroviruses, unreliable. Diagnosis should be confirmed serologically if there is any risk of exposure of a non-immune pregnant woman. There is no effective antiviral treatment. Prevention, therefore, lies in immunization. Summary journey, a mild illness but can cause severe abnormality in congenital infections, prolonged fever. Most childhood infections are acute and resolve in a few days. If not, the child needs to be assessed for complications of regional illness. That is, secondary bacterial infection. The source of infection may not have been identified. That is UTI. Often the child has developed another unrelated febrile illness. Assessment of prolonged fever is also required for prompt recognition of Kawasaki disease to avoid complication. Causes of prolonged fever are listed. Kawasaki disease is symptom of systemic vasculitis, although uncommon. It is important to establish diagnosis early because artery damage may cause morbidity and occasional mortality. Prompt treatment requires the incident. Kawasaki disease may affect children of 6 months to 4 years of age, with a peak at the end of the first year of life. The disease is more common in children of Japanese and to a lesser extent Black Caribbean ethnicity, then to a lesser extent then in Caucasians. And since it is increasing, there are now about 300 children infected annually in the UK. Etiology of Kawasaki remains unknown. There is no diagnostic test, and such diagnosis is mainly based on clinical findings alone, which are written in box, the next box. So these basically given positive prolonged disease was first infective and the other is non-infective. So we'll see that later. And pathologically, in addition to the classic features, infected children are slightly irritable and miserable and have a high fever that's difficult to manage. Young infants may have incomplete symptoms in which not all the cardinal features are present. The evolution of clinical features is shown. Affected children have high inflammatory markers, CRP, erythrocyte sediment, ESR, and white cell count with a platelet count that rises typically in the second week of illness. High inflammatory markers, they have CRP, they have ESR, and they have white cell count raised with a platelet count that rises typically in the second week of illness. Children may not have all the clinical features at the same time, so it is important to ask about relevant features in these. Many children may have Kawasaki disease and not meet the full diagnostic criteria, incomplete disease. There should be a high clinical suspicion, particularly for children less than 6 months of age with prolonged fever, even if they do not meet the classic criteria. These children are more likely to have delayed diagnosis and development of coronary artery aneurysm. The coronary arteries are affected in about one-third of affected children within the first 6 weeks of illness. This can lead to aneurysm, which can be detected on echo. Subsequent narrowing of the vessels from scar formation can result in myocardial ischemia and sudden mortality is 0.5%. Prompt treatment with IV immunoglobulin IV given within the first 10 days has been shown to lower the risk of coronary artery aneurysms. Aspirin is also given as there is no evidence of anti-inflammatory doses reduce the risk of coronary artery aneurysm. Many specialists use aspirin low dose for its anti-platelet effect to reduce the risk of thrombosis. Children suspected of having the disease but who do not have all the clinical features should still be considered for treatment. Echocardiography should be performed when the diagnosis is first suspected and at 46 weeks to identify coronary artery aneurysms. Sometimes few persist or recurs despite initial treatment-resistant Kawasaki disease, and these children may be given a second dose of IV immunoglobulins or corticosteroids or infliximab monoclonal antibody against tumor necrosis factor alpha. Children with coronary artery aneurysm require long-term low-dose aspirin, lifelong follow-up, prolonged fever. Considered is it Kawasaki disease? And summary we will do later. There is these are the clinical criteria, and these were given the causes of the lung fever, infected locus infection, osteomyelitis, atrial infection, typhoid, Bartonella, Casparidae, brucella, deep abscesses, intra-abdominal retroperitoneal, pelvic, infective endocarditis, TB, non-typical microbial infection, microbial APM complex, viral infections, EPV, CMV, and HIV, and parasitic infection, Leah, toxocariasis, and atypical sclerotica, non-infectious systemic onset juvenile idiopathic arthritis, systemic lupus erythematosus, vasculitis, including Kawasaki disease, inflammatory bowel disease, Crohn's disease, ulcerative colitis, sarcoidosis, malignancy, leukemia, lymphoma, neuroblastoma, Ewing sarcoma, microphage activation syndrome, hemophagocytic histiocytosis, and acute respiratory disorders, familial Mediterranean fever, drug fever, fabricated or induced illness, including Murchison syndrome by proxy. Now, this is the criteria. Clinical criteria presence of fever for at least 5 days with at least four of the five following features: bilateral bulbar conjunctival injection without exudate, erythema and cracking of lips, strawberry tongue, and erythema of oral pharyngeal mucosa, cervical lymphadenopathy more than 1.5 diameters, usually unilateral rash, buccal diffuse erythema, erythema multiform like erythema of the hands and feet, an acute phase, and desiccation around the nails and the subacute phase. Clinical features: fever is more than 5 days. Four of the five features. All these features given red conjunctival injection, mucous membrane changes, pharyngeal infection, red, dry, and cracked lips, strawberry tongue, cervical lymphadenopathy, rash, and extremities, rather native meters. And these are the complications which are serious gallop rhythm, myocarditis, pericarditis, chronic aneurysms for other vessels, and sudden death in the within the proximity of fourth week to second month case history. This 2-year-old boy developed a high fever of 2 days duration. Examination showed a miserable child with mild conjunctivitis, rash, and cervical lymphadenopathy. Viral infection was diagnosed. The mother was reassured. When he presented to hospital 3 days later, he was noted to have cracked, red lips. He was admitted in a full septic screen, including a lumbar puncture which formed antibiotics started. The following day, he was still febrillatable. His CRP and his SR rate were extremely high. Kawasaki was suspected and he was treated with AIV immunoglobulin overlap. His clinical condition improved and became afebrile following morning. Echo at his chest showed no aneurysm in the cornea, which are the most serious complications associated with delayed diagnosis treatment. On the 15th day of the illness, there was peeling of the fingers and toes. These are the pictures, and now it's the summary. Kawasaki disease mainly affects infants and young children. Diagnosis made on clinical features, fever over 5 days. Before the features are not virulent conjunctivitis, red mucous membranes, cervical lymphadenopathy, rash, red enematous palms and soles, or peeling of fingers and toes. Children with Kawasaki disease are often strikingly miserable, which is not improved by oral antipyretic agents. Incomplete cases can occur, especially in infants, so a high index of saturation should be maintained. In a persistently febrile child, complication, coronary artery aneurysm, sudden death, initial treatment, IV immunoglobulin, and aspirin, pediatric multi-system inflammatory syndrome. A small number of childhood appear to develop a severe cervical inflammatory response to SARS-CoV-2 virus, although the pathophysiology is not well understood, it is thought to result from an abnormal immune response to the virus. Vector children develop persistent fever, evidence of inflammation, neutrophilia, lymphopenia, and high CRP, and single or multi-organ failure. GIT symptoms, rash, and encephalitis are common. Many of these children have features consistent with Kawasaki disease, but are generally older than adolescents. Some develop severe inflammatory shock and require intensive care support. Cardiac involvement include myocarditis, coronary artery abnormalities, valve involvement, and pericardial effusions. Features may overlap with Kawasaki disease. Bacterial sepsis or toxic shock. Antibiotics are often started until infection is ruled out. Treatment includes immune modulation with IVIG, low-dose aspirin, corticosteroid. Children are often SARS-CoV-2 PCR negative, but serology positive. The full spectrum of disease optimal treatment is incompletely understood. TB, the decline is incident mortality for TB is behind the studies was hailed as an example of how public health measures and antibiotic therapy can dramatically modify disease. However, TB is again becoming a public health problem partly through its increased incidence in patients with HIV infection and with the emergence of multi-drug resistance mycobacterium MDR-TB. Spread of TB is most almost invariably by the respiratory route. Close proximity of large infectious with the index case and related to pulmonary. Pulmonary related to pulmonary cavitation, sputum smear positivity, and underlying immunodeficiency enhance the risk of transmission. There is an important distinction between latent TB and asymptomatic infection, serious TB disease, active TB. Latent TB is more likely to progress to active TB in infants and young children compared with adults. In contrast to adults, children are generally not infectious because their disease is typically paucibacillary. Children usually acquire TB from an infected adult in the same household. Clinical features are in the picture. Diagnosis of TB in children is even more difficult than in adults. The clinical features of active TB are often non-specific, such as prolonged fever, malaise, anorexia, weight loss, or focal sign infection, lymph node swelling, and TB. Lymphadenitis, majority, about three-quarters of cases with active TB have pulmonary TB. Extrapulmonary disease is less common, includes TB lymphadenitis. Articular TB, genitourinary TB, and deeper meningitis. Spontaneous sputum samples are generally unobtainable from children under about 8 years of age, but induced sputum samples can be obtained at any age. Children usually swallow sputum with gastric washroom on 3 consecutive mornings can be used to identify tuberculosis originating in the lung. From the lung using special staining techniques for AFVs, Zedin staining or aramide stains and microbacterium cultures to obtain these washings and next NG2 is passed as secretions are washed out of smoke with saline before food intake. Urine lymph node tissues, CSF neurological examination should also be performed as appropriate. Although it is difficult to culture TB from children, the rise of MDR TB makes it important to try to grow the organism so that antibiotic sensitivity can be assessed. PCR-based methods for the detection of MTB are used in parallel with microbacterial cultures, but provide limited information regarding drug resistance and do not replace culture. Whole genome sequencing of samples have been introduced in England since 2017 and provides genotypic data on mutations associated with resistance. However, phenotypic resistance in culture is still vital to ensure the most appropriate drug regimen and is prescribed. Sorry. Primary infection asymptomatic. Nearly half of infants and 90% of older children have minimal or no symptoms or sign of infections. A local inflammatory reaction limits the progression of infections. However, disease remains latent and may therefore develop into active disease at a later time. Asymptomatic children with a positive tuberculin test or interferon gamma release assay result latent TB should be given chemoprophylaxis to prevent future conversion to active TB. Example, positive TST sign. And symptomatic in this case, the local host response fails to contain inhaled particles, allowing spread by the lymphatic system region, lymph nodes, the lung region, plus the lymph node constitutes the one a primary complex. When the host cellular immune response to infection 3 to 6 week microbial replication diminishes, but systemic system of fears, fever, anorexia, weight loss, cough, chest X-ray changes, the primary complex usually heats and may classify. The inflammatory reaction may lead to local enlargement of peribronchial lymph nodes, which may cause bronchial obstruction with collapse and consolidation of the affected lung. Pleural effusion may also be present. Further progression may be halted by the host immunologic response, or there may be local dissemination to other regions of lung. Although primary infection most commonly occurs in the lung, it is also other organs including lymph nodes, bones, and joints, and genitourinary system, and the meninges. Chest X-ray shown permutation mark left hilar lymphadenopathy. And dormancy dissemination. Both asymptomatic and symptomatic infections may become dormant, subsequently reactive and spread by lymph for meteorological routes, reactivation post primary TB. This may present as a localized disease or may be widely disseminated communally TB to sites such as bones, joints, kidneys, the pericardium, and CNS. Infants and young children are particularly prone to TB meningitis. This was always fatal before antiviral therapy was